Good afternoon. Today's ACHN webinar, Overview of the New Provider Profiler Reports, will now begin. Before we start, we would like to remind everyone to please mute your phone and computer microphone for the entirety of the webinar. Also, as a reminder, use the chat box function to type in any questions, and all questions will be answered at the end of the webinar. I will now turn the presentation over to Dr. Moon for some introductory remarks.
Hi, I'm Robert Moon. I'm Deputy Commissioner over Health Systems with Alabama Medicaid, and I appreciate you all being on the webinar today. We look forward to providing some hopefully useful information to you regarding the provider profiler reports. These reports have actually been posted to the web portal or will be posted to the web portal today, and you'll be able to access your reports to review. As you know, we are in the fourth month of the new system called ACHN, or Alabama Coordinated Health Network. This system replaces the Patient First program on the physician side and several separate care coordination programs also. Physicians have just received your second bonus payment in the new system. The first one was in November, and the second one was paid about a week ago. During the first year of the program, you are receiving a bonus simply based on the number of individuals attributed to your practice. In the past, you were assigned a panel of patients to take care of going forward. Attribution is what is being used now, and attribution is fundamentally different. Attribution looks back over the past 2 years to let you know where the patient has gotten most of their care. We think this gives the primary care physician a better look at where their patients are actually going for care versus where they thought they were going. Your list of attributed patients may be smaller or larger than the panels you had in the past. Those of you that have been seeing your patients regularly will likely see more attributions. Those of you who have not seen your patients much will likely see fewer attributions. So clearly, the incentive is to see the patient. Many studies have indicated that more primary care results in better health outcomes that we all desire. At the present, your bonus is solely determined by your attributed patient list and the size of that list. This is to only be for the first year to allow for a transition to your bonus in the future being determined by how many patients you serve and your actual achievement of higher quality, more cost effectiveness, or providing patient-centered medical homes. You have the opportunity right now to do things to improve your quality and cost effectiveness scores. And the reports that we will be reviewing today will help you in targeting your activities. In the second year of the program, your bonus will be affected by the activities that you're doing right now. Now, I would like to highlight two things. As I just said, your activities right now will affect your scoring and thereby your bonus in the second year of the program. Number two, the reports you're about to see are very different from your current profiler. Now, why change the profiler? We wanted to give you specific, actionable information that you can use to improve your score. This reason necessitated a change in the profiler. Now, we've already had a couple of calls with a representative group of primary care physicians to get their input on the information included in this scorecard. We took that input and used it to develop the improved reports that you'll be seeing today. With that, I'm now going to turn the presentation over to Barry Cameron, the Director of our Analytics Division.
Thank you, Dr. Moon. The purpose of the webinar, as mentioned, is to provide ACHN participating primary care groups an overview of the new provider profiler reports. These reports will provide information on quarterly bonus payments, attribution, and dashboards that illustrate progress toward quality measure and cost-effectiveness performance targets. Participating providers will receive both summary level report dashboard information as well as recipient level summary files. Specifically, today we will quickly review the PCP payment structure and timelines associated with that, a review of attribution, quality measure, and cost effectiveness scoring. And before moving to the actual 4 new reports, we'll provide a quick overview of how to access the provider profiler dashboard reports through your provider portal. Specifically, the 4 reports that we'll cover today are the Provider Profiler Quality Measure Scorecard, the Provider Profiler Supplemental Member Summary File for Quality Measures, the Cost Effectiveness Scorecard, and the Supplemental Member Summary Level File for Cost Effectiveness. As a reminder, that effective last October 1, our new bonus incentive payment system went into effect. The bonus payments for the first 2 quarters have already been processed, and as Dr. Moon mentioned, these bonus payments reflected attribution and attribution alone. That will remain the case for the next 2 quarters. Beginning next fiscal year, the bonus payment pool will be allocated as follows: 50% for quality measure performance, 45% for cost effectiveness performance, and 5% for PCMH recognition. These will continue to be impacted by attribution. Again, as mentioned, bonus payments have already been processed for the first 2 quarters as seen in this following calendar. The first payment was processed in November of last fall, and most recently, the second quarter bonus payment was processed in January. We'd like to remind everyone that, again, beginning in October of 2020, the first calculated payment will be made for PCMH recognition. In January of 2021, the first calculated payment will be made for cost effectiveness. And finally, in July of 2021, the first calculated payment for quality measures will be made. It's important to note that you are all determining right now how you'll be paid in future periods. And these reports were designed to assist you in this determination process. Let's review attribution, starting with the guiding principles of why we developed the methodology. First, consistency with ACHN's principles of payment for activities as well as outcomes. Continued emphasis on care coordination and health outcomes with a focus on preventative care. Acknowledgement that some recipients do require specialist care. And finally, evaluation of activities and determination of bonuses at the group level. Again, as a reminder, the definition of attribution, it is the process that is used to associate a Medicaid recipient to the PCP group that provides primary care to that recipient. As a reminder, groups must sign 2 agreements, one with Medicaid and one with the ACHN entities in order to participate. Under the ACHN program, recipients are attributed to PCP groups and is based on historic claims utilization. Therefore, PCPs are encouraged to continue seeing patients as medically necessary on a consistent basis to increase the likelihood of attribution. Attribution is a critical factor in determining the distribution of bonus payments and is the sole determinant in year 1, as we've previously mentioned. Finally, attribution replaced panel assignments beginning in October. Under ACHN, the Patient First program ceased to exist as of September 30th, 2019. We would note that a smaller number of attributed members compared to members in previous panels do not necessarily equate to reduced payment levels, as Dr. Moon previously mentioned. Now, a review on our guiding principles for quality metrics. They are based on CMS's collection of quality measure data from all 50 states in an effort to strengthen quality of care and health outcomes. All measures are nationally validated and have specific standard specifications. ACHN benchmarks are based on quality measure performance scores as reported by the various states and will be adjusted as necessary. Benchmarks are now posted at www.medicaid.alabama.gov, and these will be updated on an annual basis. The primary focus of quality measures is to measure attainable improvement in healthcare outcomes. And to qualify for quality bonus payments, PCP groups must achieve a quality score of 50% or higher. That is, they must meet the targets for at least half of their applicable quality measures in any given quarter. There are a total of 8 provider quality measures, divided into child quality measures and adult quality measures. The 4 child measures are as follows. W34CH, which is well child visits in the 3rd through 6 years of life, adolescent well care visits, childhood immunization status combination 3, and immunization for adolescents combination 2. The adult quality measures are as follows. Antidepressant medication management continuation phase, comprehensive diabetes care, which is A1C testing, follow-up after emergency department visit for alcohol and other drug abuse or dependence, and finally, chlamydia screening in women ages 21 to 24. It's important to note that practices will be scored only for the measures for which they have recipients in the denominator. Guiding principles for cost-effectiveness scoring. Also, these principles are consistent with the overall ACHN principle of paying for activity with a focus on outcomes, with an acknowledgement that risk levels will vary across practices, and as a result, our scoring and results are risk adjusted using validated methodologies. Again, evaluation of activities will be made at the group level, and to qualify for the cost effectiveness bonus payments, PCP groups must be at or below the statewide median cost effectiveness score. Cost effectiveness will be scored as follows. It will start with a comparison of the group's actual 12-month per member per month, and it will be compared to a risk-adjusted expected per member per month. The resulting score is the cost effectiveness score, and every group will be ranked on the score that is derived from their actual PMPM versus the expected PMPM. Every group in the state will be ranked, and again, as mentioned previously, bonus payments will be awarded to the groups that are at or below the median cost effectiveness score. We would also note that this expected PMPM calculation is based upon the statewide ACHN population, and it is risk adjusted. We also exclude certain costs. That is for the purposes of accounting for that certain costs are beyond the control of certain or most PCP groups. This would include drug rebates as an example, as well as certain waiver costs. Now we'll move on to the section of the webinar where we're going to go through some of the provider dashboard reports. Again, there will be 4 reports that we will review today. The first is titled MGD S362Q Report. This is otherwise known as the Provider Profiler Quality Measure Scorecard. As you will see, this is a summary level report that illustrates your current scoring. The second is named MGD M362Q, otherwise known as the Provider Profiler Supplemental Member Summary File for Quality Measures. This is a report that reveals how much each individual recipient affects your scoring. The next, we'll go through the Provider Profiler Cost Effectiveness Scorecard. This is MGD S364Q Report. This again will be a summary level report that illustrates your current scoring relative to cost effectiveness. And finally, a recipient level cost effectiveness report known as MGD M364Q. This is a report that reveals, again, how each individual recipient affects your score relative to cost effectiveness scoring. Before we review some of these reports, we would like to quickly go through how to access these reports through the provider web portal. First, you'll go to the web portal link, which is seen here, www.medicaid.alabamaservices.org/AL-portal. To access the login panel, click on Account and then click Secure Site, where you will enter your login credentials as always. Next, you will have the ability to click on the Trade Files tab and download options. This is where you will see a variety of different reports available to you. Highlighted in the red below are the 4 new provider profiler reports related to quality and cost effectiveness. Next, we'll select the Quality Measure Scorecard report as our example. Here you'll see the provider portal showing MGD S362-Q in the drop-down list, as seen in the highlighted red box below. This report will now be available for download from the web portal. The report will be available, this particular report will be available in a PDF format. I would note that the recipient level reports are also available in PDF formats, but will also be available to download as an Excel file. Before we go through examples of these 4 reports, we would like to provide information for more detailed resources that are available to you through our website. The first website, medicaid.alabama.gov, this link will specifically take you to 3 webinars that were recorded in September that are all related to attribution, quality measures, and cost effectiveness. These webinars and presentations go into detail around the methodologies used and the steps used to calculate the bonuses. We will not go into those detailed steps today, but those are available for you at any time. There's also a direct link to frequently asked questions around ACHN. And finally, we have an email address, achn@medicaid.alabama.gov, for you to submit your questions for official agency responses. Now we'll review the first report, MGD S362-Q, which is the Quality Measure Scorecard. Again, the principles for the design of these is trying to give actionable information for all groups as they strive to attain their quality and cost effectiveness measures. This report is essentially divided into 3 sections. The first section is the summary, which has the group's total number of attributed ACHN members. In our example here for ABC providers, this provides the total number of attributed ACHN members for this reporting period, which is January 2020 through March 2020. Again, we are in the summary level portion of this report, starting with the total number of attributed ACHN members. Again, this is the statewide number of attributed ACHN members for quarter 2. That would be the January 2020 through March 2020 reporting period. Next, we move on to the attributed members in the groups meeting the quality score minimum. What this is that members attributed to groups and practices that actually met the quality measure minimum of 50%. Next is the members attributed to the PCP group this quarter. This will be specific to your practice. And next is the estimated bonus payment for quality. Again, quality payments, bonus payments for quality measures will not be made until July 2021, but this provides guidance toward attainment of that goal. The next section is the actual scorecard section. For every quality measure report, this includes the following 8 rows, which are, again, the pediatric and the adult measures that we reviewed earlier. For this, we'll move left to right on your screen, starting with the numerator and the denominator. What these numbers mean is the denominator is the number of recipients in this respective practice that qualified for inclusion in the specifications for this quality measure. And in this example, we'll use W34-CH, which is well child visits in the 3rd, 4th, 5th, and 6th years of life. The numerator is the number of recipients in this practice who met the criteria of the specs. So we simply take the numerator divided by the denominator, and that gives this group a quality score of over 78%. Moving left to right, we see the baselines and the benchmark. The baseline is the statewide average for this quality measure. The benchmark, otherwise known as the target, is the metric that the groups will need to attain in order to meet the target for this quality measure. So in this example, this quality score of 78% exceeded the benchmark of 67% or 66.7%. Thus, no improvement is needed during this quarter, and the group met the target for this particular quality measure. Because this is, in this hypothetical example, this is a pediatric practice, they only have recipients in the denominator for 4 of these measures, and it will accordingly be scored only for 4 quality measures. In this example, they met the target in 3 of 4 quality measures, thus qualifying them for a quality measure bonus. And the final portion of this report, going down, starts with quality bonus payment calculation methodology steps. Again, we will not go into the detail of the methodology today. You can refer to previous webinars for that, but these reports will provide a step-by-step instruction and description of how the bonus payments would be calculated for quality. Next, we will move to report MGD M362-Q. This is the provider profiler supplemental member summary file for quality measures. Again, we will use a different practice in this scenario, and we'd like to mention that we recognize the fact that this is a very detailed and busy report, but this is, again, designed to be actionable. So the guiding principle behind this design is if there is a specific measure that needs to be worked on for improvement for any given quarter or any given reporting period, the provider or the provider group will be able to identify the specific recipients that are affecting that particular metric and that particular score. So in this example, with XYZ Medical Associates, we'll focus on the Medicaid ID. These are obviously fake Medicaid IDs, but if you go about halfway down the list of IDs here for recipient ending in 12 or recipient ID 12, you'll see that if you scroll over 5 columns, you'll see the measure AWC-CH. Again, this is the adolescent well care visit. And you'll see that for this particular recipient, they qualified for in the denominator as well as the numerator. So in this case, that recipient had a score of, had a numerator value of 1 and a denominator value of 1. If you scroll down to recipient 20, you'll see where this recipient qualified in the denominator for this measure, but did not in the numerator. And therefore, the sum for the recipients for this practice, for this measure, added up to 1 for the numerator and added up to 2 for the denominator, giving them 50% for this particular metric. So again, this example has a relatively small number of recipients, but again, the concept behind this report is to provide practices the ability to go to any recipient for any quality measure and see whether or not they qualify for inclusion in the denominator or the numerator. I would also note that, again, this is a PDF that we're viewing now. These recipient level reports will also be available to download in an Excel format. Now we'll move on to the next report, which is MGD-S364-Q. This is otherwise known as the Provider Profiler Cost Effectiveness Scorecard. In this example, we'll go back to another group, ABC Medical Associates, that had an attributed number of recipients of 769. And again, much like the quality measure scorecard report, this report has 3 primary sections. The first is the summary level, starting with the total number of attributed ACHN members statewide, and in this example, that's a little over 497,000. Next is the attributed members in groups that are at or below the median threshold. In other words, this is the number of recipients attributed to the PCP groups that have met the cost effectiveness score that is at the statewide median. Again, we then take the members attributed to the PCP group in this quarter, 769, and finally see the projected cost effectiveness bonus based on the cost effectiveness scoring. The section below, PCP cost effectiveness bonus payment scorecard, provides again a scorecard that shows how each group is scored from a cost effectiveness standpoint. Every practice will receive a report that shows by service type. In this case, you can see where we have grouped the service types into inpatient, outpatient, mental health, pharmacy, physician services, and other groupings. Every practice will receive a report that shows their overall PMPM and what service types contributed to this PMPM. It will also compare these PMPMs to the statewide PMPM. Again, that would be the statewide ACHN per member per month. Going left to right, you'll see in this example, by comparing the practice PMPM of $166 to the statewide PMPM, that gives us a cost effectiveness score going left to right of 0.37. This is taken by taking the expected PMPM, or taking the actual PMPM divided by the expected PMPM of $448, which is derived from the statewide PMPM and applied to this practice's risk score, in this case of 1.56. As you can see in this example, this cost effectiveness score of 0.37 would be below the median threshold of 0.58 and therefore below the statewide median. In this example, this group would qualify for a cost effectiveness bonus. And in the final section of this report, you can also, again, see the bonus payment calculation methodology steps. And again, every practice will receive this on a quarterly basis. The final report that we will review is report MGD M364-Q. This is the Provider Profiler Member Summary Cost Effectiveness Report. Again, this is at the recipient level. This is designed, again, much like the quality measure supplemental file, this is designed to provide practices the ability to see any given recipient and how they are impacting and affecting their cost effectiveness scoring. So in this particular example, again, we'll go back to XYZ Associates who have a total of 23 recipients. You can see the total at the bottom. The total cost for this particular group is $215,000 for the period, which is a 12-month period based on dates of service. applied to their total member months of 274, you will see at the bottom this gives this particular group a PMPM of $785. To see what recipients drove the cost in the subsequent PMPM, let's direct our attention back to the second member, that is the member ID ending in 02. You can see in this particular case, this individual recipient incurred costs for this period of $6,200. They had 12 member months and a subsequent PMPM of $518. And in this case, you can see that the inpatient cost for this particular recipient is what drove the majority of these costs. So in this example, one thing I would point out that just because this particular PMPM for this group is $785, it does not mean that they would not qualify for cost effectiveness. What you don't see here, but this particular group had a risk score of over 4.4, giving them a high expected PMPM of almost $1,300. That would make them cost effective with a score of 0.61, which would be below the statewide median. So again, that's an example of how, although the PMPM might be high relative to other groups, because the acuity and the risk level of the recipients in this group is high, that does not necessarily disqualify them from cost effectiveness bonus considerations. So with that, we will provide the link back to ACHN resources, and Dr. Moon will have a few closing comments, and then we'll open it up for questions.
Sure, this is Dr. Moon back. I just want to make a few more comments, and then we'll start going through the questions that you all have submitted. First of all, just some points to sort of reinforce that Barry has pointed out already. Again, your activities right now that you're doing now will affect your scoring and then the size of your bonus in that second year. Obviously, even now, the number of attributed patients you have affect your bonus, but the actual scoring on these different methodologies will affect the size of your bonus in year two. The second point I'd like to reemphasize is that these reports obviously provide actionable information at the individual recipient level. I mean, you can actually look up and see which particular given patient is helping your score or not helping your score, and then to whatever level you can intervene, you can intervene. I'd also like to reemphasize that if you don't have patients in your panel that fit a given quality measure, that's not held against you. Barry demonstrated that in his presentation. But I think that's an important point to stress. If you're a pediatrician and you don't have adult patients, adult scoring is not held against you. The next thing to stress is risk adjustment. As you saw, risk adjustment can have a very significant impact to help you in the sense of meeting the cost effectiveness target. So there's no reason to avoid more complex patients. That will be taken into account, and there will be a risk adjustment of the cost effectiveness such that you could still be possibly in the bonus pool even though you had sicker patients. Obviously, it would be to your advantage to work with the ACHN to get needed case management services for those individuals that might be affecting your score that you feel like could be impacted, and that could help quite a bit. And then the last thing I would say before I turn it back over to Barry and his team would be, we recognize it takes several reviews of this to kind of get the hang of it and what you're looking at and sort of what you need to interpret on it. You will be able to review this webinar as many times as you would like. It will be ultimately posted to our website. There are already many other webinars with great detailed webinar presentations about various parts of this that you can review today. They're already posted, and this one will be posted very soon. So again, we recognize it takes a few times looking at this to get the hang of it, and we would encourage you to do that. But you should pretty easily be able to see that clearly there's actionable information here in terms of individuals that are helping or hurting your score one way or the other. So with that, I'm going to turn it back over to Barry and his team to answer any of the questions that have been submitted.
Thank you, Dr. Moon. We did want to answer some questions that have been asked earlier, and we did review a few of these during this presentation. A couple of questions. When will the actual calculated bonus for cost effectiveness start? Again, the actual bonus payment for cost effectiveness will begin January of 2021. And again, that would be based on attribution for that period, but it would be based on claims data from October 2019 to September of 20. Right. I would note that with this report, you're able to see what it would be if, in fact, cost effectiveness and quality measure calculations were part of your bonus. Again, attribution is what drives your bonus for this year, for this first year in the program. But these reports are designed to show you what we would have expected your bonus to be based on cost effectiveness and quality scoring. Again, this is meant to serve as guidance and to be actionable for you in your practice.
All right, so we have a couple questions coming in. How do you add more diagnoses in the 4 attached to one CPT code? In other insurances, we can add blood pressure and include more diagnoses. How should we add for Medicaid claims?
If you file electronically, more than 4 can be submitted. And if you need assistance with your PES, then you need to contact the provider reps to help you.
What defines a group practice? Practice site or tax ID? Will quality measures be claims driven? How will this affect the clinics that are rural health?
Take the first part.
Yeah. What defines a group practice is how you register with Medicaid. It could be practice site or it be tax ID. It's however you enrolled as a group provider. It's the same that you did with your PCP agreements and your participation agreements. It's however you decided to register. Will the quality measures be claims driven?
The majority of our quality measures are claims driven. We do incorporate data from other state agencies as applicable, such as immunization registry data.
How will this affect clinics like rural health?
Rural health clinics if they have signed agreements with both the agency and with an ACHN, they are eligible for a bonus as long as recipients are attributed to them.
Okay. When will reports be available to provider groups? Do we have to obtain reports from our ACHN? No, reports will not come from the ACHN. This is that ACHNs do not receive attribution lists and do not receive a copy of these reports. If you would like to work with the ACHN and need the assistance of the ACHN to help improve your measures and to work with patients who might not be as compliant, you would need to share these reports with them. That's why we allowed you to download them as Excel version and work with them. They're actually, I think most of the ACHNs would agree that they prefer the Excel version so that they can work and sort those patients. And the reports will actually be available this afternoon. The first round of reports will be in your file cabinet this afternoon. How do you dismiss a patient so they are no longer attributed to you? Well, attribution and your assignments are two different things. Attribution is based off of historic care provided by a provider. So as long as the patient continues to come to your office and you see them and you get billed and paid for them, then they will always be attributed to you. The assignment process, it was a prospective, and we've gotten rid of that since this past October. Is the patient lock-in still in effect? Yes. Are all ACHNs accepting referrals at this time? Yes, as far as I know, we have no issues with ACHNs. I don't know if you're meaning referrals for care coordination or if you're needing a referral as a specialist for a provider. But yes, all the ACHNs are up and running. How is the AMM, AD, antidepressant medication management measure calculated? Is it based on pharmacy claims?
So for the measure, the pharmacy claim is certainly can you hear it? The AMM measure is a pharmacy claim driven measure.
All right. If you do not use PES, but file through a practice management system, will claims be accepted using CPT 99080 to add additional diagnosis. That would be a question I would ask. I would refer you to your practice rep through DXC. How do you determine who is high risk? Some patients go to the ER even if you advise them not to and demand specialists and referrals, etc.
Our risk levels are based on, as mentioned earlier, a nationally validated methodology based on what we call MARA risk scoring, which is Milliman Advanced Risk Scoring. And so the risk scores for each practice is what we call a concurrent risk score. That is, we take into account every recipient's claims history and other factors, diagnosis history, and we use that to project what their actual cost should have been. So every recipient's claims history is taken into account in risk scoring. And this would include ER claims, among others.
If data is claims driven, how will the ACHN get quality measures from rural health claims? Several years ago, even as we started developing that old project, the RCO, we did work with the Rural Health Association as well as the Primary Health Care Association and worked with all providers to try and encourage them to bill and submit claims as appropriate to let everything that they do and not just bill straight under the encounter claim. You still get the encounter rate, but as long as you add all the CPT codes and diagnosis codes that you actually are from your patients, we would get a copy of those in the claims processing system, and we would be able to calculate your measures. Again, if you have claims-specific questions, I would refer you to DXC's provider reps because that's where they'll be able to help you. How do you access the file cabinet you mentioned? If you want to go back on the slides.
Yeah, can we go to, I think it's starting with slide 13. Okay, looking at slide 13 in the presentation today, again, you would go to your provider web portal, go to the following link, www.medicaid.alabamaservices.org/AL portal. You would then log in, to access the login panel, you would enter in your login credentials with your username and password.
And these would be the same credentials that you use for the web portal, so if your staff does eligibility checks and things like that, it'd be the same access. And I will give you a heads up. We will be posting this webinar, a copy of these slides, as well as a couple other documents that you'll be going through to help provide additional resources, including some of these sample reports will all be on the Medicaid provider website under the ACHN side. So we will send out a list to everybody that this has been posted, and we'll also the ACHNs will be able to work with you kind of going through everything. Also, if you have any issues getting onto the portal, that's also another resource where the DXC provider reps will be able to help you out. Is there a list of antidepressant medications that are included? As Barry said, all of these measures that we use are CMS core measures, so all of the specifications can be found on the website, on CMS's website, but also we have provided all the information, and the ACHNs also have all the specifications for the measures. So this is a good opportunity for you to partner with the ACHNs, not only on working with different recipients, but this is where they can come in and work with you to improve your quality measures and for you to understand these measures. So I highly encourage you to reach out to your ACHNs. On the report MGD S364Q, there is the cost-effective score. Can you review how we get the cost-effective bonus?
Yeah, so the specific cost-effectiveness methodology, the detailed step-by-step methodology, I would reference the webinars and presentations that were done in September. But specifically for any group's cost-effectiveness score, it starts with taking the actual cost incurred based on a data service basis on a rolling 12 months. We allow for 3 months of claims run out. We then apply that group's particular risk score, which we described earlier is described in the MARA risk scoring. We apply that group's risk score to a statewide peer group, which is the statewide ACHN cost effectiveness score. That gives each group an expected PMPM based on their risk level. It compares that to the actual PMPM. And we then take the ratio to come up with the cost effectiveness score. Every practice is scored in the state is then ranked, and we have chosen the median as the cutoff. Every group that is at or below that median would then qualify for a cost effectiveness bonus.
Okay. Let's see. What about OBGYNs? Are we eligible for the bonus? Yes and no. There are two separate bonuses if you are a delivering healthcare provider, a DHCP. Those bonuses are if you see a patient for a prenatal visit within the first trimester, or if you see a patient for a postpartum visit between days 21 and 56 after delivery. Now, if you're an OBGYN and you are also acting as a primary care provider and have signed a PCP agreement with the agency and a participation agreement with your ACHN, then yes, you would be eligible for these bonuses, but you must meet both requirements. So you would have to do, you'd have to meet the primary care bonus requirements to get these bonuses. Do we only calculate the medications that we prescribe? And the answer would be no, it is only those that are actually filled because we run off of claims data, correct, Barry?
Let me.
Yes, but it would be all medications that are prescribed and filled by a patient, which goes to our next question. What if one of our treated patients go to a specialist to receive other medications? Yes, if they have those medications being filled, then yes. Same thing with ER. But again, this is an opportunity to work with the ACHNs because the ACHNs actually get daily pharmacy feeds, so they know exactly what all patients are taking. And so I would reach out to either their pharmacy staff or to your care coordinator if you happen to have one in your office or who your contact is, because they would have access to everything that has been paid for prescription-wise for a patient. Let's see, how do we find out who is our assigned ACHN rep? That would, you would have to contact the ACHN within your region. Again, if you go to Medicaid's website, under ACHN's tab, go to providers, and there's a provider list. There's a contact information and a provider number for every ACHN. The assignment is based off of where the county resides. So you might be on a border county, so you might actually have reps from different ACHNs, depending upon where your patients come from.
Couple more questions. And this actually came in from a previous webinar. If I take care of critically ill patients, will the cost of my patients be higher? And is there any way that I'll be eligible for the bonus? Yes. Again, that is why we're calculating your expected PMPM with risk adjustments. In other words, if your patients are sicker, the average risk score of your attributed group will be higher. So, for example, if the average risk score of your attributed group is 2, that essentially reflects that your patients are sicker because it estimates that your attributed group is 2 times higher than the average attributed group. And so again, this risk score is applied to the statewide PMPM to calculate your expected and then compare it to your actual. So cost alone will not impact your cost effectiveness score. The risk and acuity level of your attributed number of recipients is taken into consideration as well. Why did you choose median as a cutoff? Yes, we mentioned that a couple of times about the median as a cutoff. Essentially, it's because we find that both costs and risk scores are highly skewed towards the more expensive patients. And as a result, the average calculation of the cost efficiency is highly skewed as well. So choosing the median reduces the influence of some of these higher cost outliers.
All right. What comes under combo 2 and then combo 3 for the different vaccines?
So Combo 3, that is you asked about Combo 2 as well as Combo 3. Combo 2 is the adolescent immunization measure.
The meningococcal vaccine, Tdap, and HPV. Those three make up Combo 2. For Combo 3, again, another childhood immunization measure, but it includes the Tdap, and it includes the IPV, it includes MMR, it includes your Hib, hepatitis B, and varicella, and a PCP. But again, I would point you to the CMS website to look at this specifically, so you can look at it in more detailed fashion. This is off the top of our head. We want you to be able to look at it in detail and look at the standard.
Again, also, you can always work with your ACHN because they'll be able to provide that. These are the type of questions at medical management meetings where they can work with. Again, if you have any questions, please enter them in the chat box and we'll get to them. What about, does the recipient have to be seeing me for a full year to be counted towards my bonus scores?
No, risk scores are calculated monthly actually, but the risk score is much more accurate with the full year's worth of data. But I would also remind you that recipients cannot be attributed to your practice until they've had at least 3 months of eligibility out of 24 in the ACHN. Again, that methodology is in previous presentations. So the risk scores of recipients attributed to your group will at least have 3 months of eligibility in claims.
If a patient is seen for prenatal care in one region by one physician and delivers in a different region with a different physician, all same practice, which region applies? Patient's home region? So this gets to a little bit of a different issue. We assign a recipient to an ACHN based off of their county of residence. But we allow our recipients to see whichever provider they choose to wherever they might be located. So for this example, they might be seeing the patient is seen in a physician's office in their home region, the county where they're in the region where they've been assigned for care coordination, but maybe there's not a hospital to deliver close to them, and they have to travel across to a different region's border to deliver. For that case, all of the care would still be provided by that home ACHN, and so all of it is tied to that region, to where the recipient is residing. If the recipient moves between the initial prenatal care and then postpartum and delivery, it would be based off of the county of residence when the report is run. If that recipient's address has been updated and the recipient has been assigned to a new ACHN, all of those go into effect. But again, these measures and the quality reports and the bonuses are not tied to where the recipient is located. It is tied simply to whether that patient is attributed to you. Where do I find the requirements you were talking about that were reviewed in September to see what are the measures to meet for the cost-effectiveness score? So all of, for the cost-effectiveness score, Barry can answer that in a second, but the quality measures that we actually have and the targets, those are all on the ACHN website, on Medicaid's website. Again, go to Medicaid, go to ACHN, and then go to quality measures, and you will actually see both the file for the ACHN quality measures and their targets, as well as the provider measures and the targets for those.
And again, we had the link up here for the previous webinars, but the question specifically around cost effectiveness, the methodology itself, the risk scoring component of that is based on a proprietary algorithm that is from a company called Milliman Advanced Risk Adjusters. So there are some proprietary components of that which we cannot disclose publicly, but effectively every practice has their actual cost applied to a risk score to compared to a peer group that ultimately results in their cost efficiency score. And again, we use the median as the cutoff to determine whether or not that practice is qualifying for the bonus.
And the MARA risk adjustment formula is a very common risk adjustment model designed for Medicaid populations, correct?
That is correct. It's designed for Medicaid populations, and we have applied our own algorithms to that to adjust for the nuances of Alabama Medicaid.
So we only have about another 3 minutes, so we wanted to check in and see if there's any additional questions. If not, we will end this webinar. Again, like I said, this recording will be posted to the website. Templates, the sample reports that we've demonstrated will be posted to the website, as well as additional other materials that you can go back and walk through. The types of the measures, how to calculate these step by step, some nice posters to kind of really overview the concepts of attribution, cost effectiveness, and quality, as well as links to the webinars previously done back in September and October about attribution, about cost effectiveness, and about quality. So again, thank you for everything. We did get one last question here. What date would your application have to be approved by to get the November bonus payment? To get the November bonus payment, so the last one came out in January. To be eligible for the January bonus payment, you had to have your agreement in-house by December 1st. It has to be in a month prior, it has to be effective for the month prior to the calculation of the quality bonus. So the next one will be paid out in April, so you need to have all of your agreements, both the PCP agreement and the participation agreement, by March 1st. Thank you for attending, and